Welcome to the HFMA Talk podcast, the podcast for NHS finance. I'm Alex Hunt, content and social media executive at the HFMA, and today we're diving into some of the biggest news stories from the past month in the healthcare finance community. It's been a significant few weeks with the surprise resignations of NHS England CEO Amanda Pritchard and CFO Julian Kelly. And if that wasn't enough, Prime Minister Keir Starmer has announced plans to abolish NHS England entirely. This comes at a time of huge operational and financial challenges for the NHS across the whole of the UK, as it looks to develop plans for 2025-26 that deliver sustainable services within budget. More on that shortly. First, let's get into those major changes at NHS England. I'm joined today by Steve Brown, editor of the HFMA magazine Healthcare Finance, to help us explore this story and the wider challenges facing the NHS.
Thanks, Alex. I think the scale of the announcement in the middle of March took everyone by surprise. Earlier in that same week, we'd heard about more executives stepping down from the NHS England board, including, as you mentioned, Julian Kelly, the chief financial officer. And alongside this, Amanda Pritchard had announced that there would be a radical reduction in the size of NHS England, with the size of the centre cut by about half. But this didn't mention the full abolition of the arm's length body, and it's undeniably a shock and a very difficult thing for the roughly 15,000 staff working in NHS England. The stated aim is to reduce duplication and bureaucracy and put more funding back into the front line. But it seems odd to announce the result, a 50% reduction in headcount across the department in NHS England, without a more detailed review to identify what functions are duplicated and what could be removed. As the King's Fund's Siva Anandasiva told the Commons Health and Social Care Committee last week, given the relative sizes of the two bodies, 15,000 versus about 4,000, it's simply not plausible to have duplication that would release 50% of staff. Presumably all functions will have to contribute to the 50% reduction, but it's hard to see exactly where they might come from, perhaps particularly within finance. For example, the costing team has already faced some major cuts over the last year as NHS England went through an earlier headcount reduction. Costing is central to so many activities in the NHS in England, informing national prices, which are still used for elective activity, and underpinning the model health system, to say nothing of its use to inform decision-making. Ministers and officials want more benchmarking of costing data to drive that productivity improvement that's so essential to future sustainability. The same work as is currently undertaken will still need to be performed in terms of allocations and payment approaches. In fact, there's lots of talk currently about the need to develop incentives and financial frameworks that support the government's shift out of hospital and into community. Accounts still need to be prepared and business rules developed and overseen. And with integrated care boards dropping their provider oversight role, you'd think, if anything, there'd need to be more support at the centre. It's still too early to tell how this will all pan out. It could take up to 2 years for NHS England to actually disappear. But the one thing we know from history is that reorganisations tend to be a distraction and can delay reform rather than accelerate it.
So, Steve, how has the HFMA reacted to this news?
First of all, the HFMA's Director of Policy and Communications, Emma Knowles, recently reflected on her own experience of working for the Audit Commission when it was abolished back in 2010. In a blog on the HFMA website, she empathised with the staff in NHS England who are bound to be upset by the seeming lack of value attributed to their work and some of the unhelpful language that has accompanied the changes. Describing NHS England as the world's biggest quango was not meant as a compliment. She offers hope for those involved in this reorganisation, with new opportunities likely to arise for those displaced. But she questions the timing of such a major reorganisation when the service has such a busy agenda, and wonders how it will help the NHS meet the government's 3 shifts to deliver an improved and sustainable NHS. And we shouldn't forget that this reduction is also being mirrored in integrated care boards. It's really difficult to see how this can happen without a clearer understanding of what exactly ICBs are expected to do in this new structure. There's lots of talk about strategic commissioning, but very little about what this will entail. and specifically the functions they'll no longer be undertaking. The government wants ICBs to work with partners to develop a new neighbourhood model for health and care, but there are already concerns that ICBs will sacrifice place-based structures to meet the new cost-cutting targets. And what about the move to population health management? ICBs were definitely seen as driving that programme, but few areas have been able to make much progress given the financial context and the focus on elective waiting times. And that's with the current staffing levels. There are also some really practical considerations. We really need a clear definition of the running costs that need to be halved, and the timeline by the third quarter of the new financial year seems improbable given the sheer size of the cuts and the need to comply with HR policies.
Thank you for that update there. For our HFMA members in England, we know that the changes announced the other week will be difficult for many of you, and we are working on how we can support our members, and we'll update you as soon as we can. In the meantime, please get in contact with us via info@hfma.org.uk if you have any suggestions about how you would like us to provide support throughout this period. Following on from the success of the HFMA Health Inequalities Finance Fellows programme, we have recently launched the Value Improvement Finance Fellows, or VIFs. The 12-month programme is aimed at senior-level NHS finance professionals who are passionate about implementing value-based healthcare approaches in their organisations and systems. It will give participants the opportunity to attend monthly presentations and learn directly from value-based healthcare experts and from peers who have successfully implemented value-based approaches. Alongside this, fellows will be able to network, get advice and share information with fellow VIFs and gain access to relevant HFMA and Healthcare Value Institute resources and events for the duration of the programme. Applications are open until the 17th of April 2025. For more details about the programme, what will be expected of participants, application eligibility criteria, and to apply, visit hfma.to/VIFs. You can find that link in the show notes. Now, back to the episode. Okay, let's talk a little bit more about those challenges you keep mentioning that are facing the NHS right now then.
Okay, well, no one working in the NHS will be unaware of both the operational and financial pressures facing the service. But there may be less understanding among the general public, given the apparently relatively generous settlement in last October's budget, relative that is to many other spending departments. But the simple truth is that the NHS has a real financial headache. So the budget may have suggested a 3.4% average real terms growth for health and social care in England over the 2 years from 2024-25, and 4% for the NHS. But this doesn't feel like an increase in purchasing power, with so much of the growth going on pay for staff. NHS England has acknowledged that in 2025-26, funding will feel more like a real terms cut, and that the NHS will need to reduce or stop spending on some services and functions and achieve unprecedented productivity growth in others. And this is not an England-only problem. In the March issue of Healthcare Finance, we put a Welsh and Scottish lens on the financial challenges facing the NHS. Both countries face significant operational and financial challenges, both in the coming year and beyond. The problems have been building up for some time, in part a hangover from the COVID-19 pandemic, which has seen waiting lists expand and the complexity of cases increase. But it's also a result of demographic changes and, in particular, an ageing population. In Wales, overspends have been a fact of life for a while, with all 7 health boards reporting a cumulative overspend for the 3 years from 2021-22 to 2023-24, despite a statutory duty to break even. That overspending continued into 2024-25, with 6 boards starting the year forecasting a 220 million deficit on a total allocation of around 9 billion. Welsh Auditor General Adrian Crompton said last year that it was clear the statutory framework to drive financial sustainability in the NHS just was not working. And although October's UK budget triggered more funds for the Welsh Government, which channeled a lot of them to its NHS, this in no way addresses the extent of the financial challenge. The boards will still end the year with a collective deficit and carry that deficit into next year. Part of the problem is the reliance on non-recurrent savings to deliver financial positions each year. Health boards need to make efficiencies each year to deliver their financial plans, and in recent times the level of savings needed has been growing, with a 50% increase from 140 million to 210 million between 22-23 and 23-24. But it's not just the level of savings needed, but how they make the savings that's important. Ideally, these savings should be recurrent, a permanent reduction in the cost base. But a significant amount of the savings in recent years have been non-recurrent in nature. These are one-off savings. So, for example, postponing filling a vacancy for the remainder of the financial year and getting by with a reduced staffing level. Unless this staffing reduction can be made permanent while still being able to meet demand in a safe way, then the position needs to be filled and the expense reappears. An organisation that breaks even on the back of non-recurrent savings is really carrying an underlying deficit. Wales is not alone in relying on non-recurrent savings to hit, or perhaps more accurately, to get closer to financial balance, but it is a growing issue for it. According to Audit Wales, more than 40% of those 210 million savings made in 23-24 were delivered non-recurrently. And in cash terms, these non-recurrent savings have increased significantly over the last 3 years, from 19 million in 2021 to nearly 87 million in 23-24. Those non-recurrent savings basically have to be refound in the following year, alongside meeting new efficiency requirements that are built into government funding levels. And Scotland's no different. In fact, Audit Scotland pointed out recently that 63% of the savings delivered in 23-24 were non-recurring. Forward plans remain overly reliant on non-recurring savings, and these underlying deficits are seen as a risk to financial sustainability. All in all, it reflects an NHS across all 4 home nations that is increasingly focused on the short term, managing year to year rather than planning for the longer term. If there's one aspect of current developments in England that Scottish finance leaders look at with some envy, it's the promise of a long-term plan covering 10 years that's due to be published this summer. Having a plan doesn't guarantee its delivery, but it is a start, forcing the government to look at all aspects of service delivery in the round and consider the investment needed to realise the goals. In reality, the solutions are pretty much agreed upon. We need more services delivered in the community and away from expensive hospitals. There needs to be much more of a focus on prevention and condition management rather than waiting for patients to present with an acute problem. And there needs to be an increase in productivity, ushered in by much greater use of technology. But setting high levels of ambition is the easy part. Trying to turn this into reality is so much harder, particularly with continuing high levels of demand and without increased resources to finance the transition. In an ideal world, the NHS would develop new community-based models while continuing to tackle its existing hospital waiting lists. But current funding would in no way cover the double running costs needed. The NHS has a far more difficult task, looking to develop those new models of care, but paid for by reducing spend in more traditional pathways. And if we are going to move to new models of care, we need to be thinking now about the staff needed to run those new models in future years, both in terms of the numbers and the skill mix. This is something that Audit Wales recently focused on in its report addressing workforce challenges in NHS Wales. It found that at both national and local levels, high-level ambitions around workforce planning were not grounded in a practical understanding of how health and care services would be shaped in the medium to long term. In other words, we need to develop a much clearer view of what sustainable services will need to look like in future and start planning to have the right staff to deliver those new models. All in all, it's a huge agenda.
Yeah, it definitely is. And I find that really interesting, and I'm interested, how do these financial pressures compare historically? Are we in an unprecedented situation, or have we seen similar challenges before?
Yeah, it's a good question. It's not unusual to find NHS leaders describing the latest year as the hardest ever, but there's a really big argument for suggesting that the current set of challenges really are unprecedented. There's something of a perfect storm. We have an ageing population, and people typically need more care as they get older, but the NHS is still recovering from the shock of COVID-19. At the end of January, the waiting lists in England stood at some 7.4 million, involving around 6.3 million unique patients. The problems didn't start with COVID, but the waiting list has certainly ballooned since. There's a real focus on recovery, but those waiting lists remain stubbornly high. Productivity took a real hit during COVID, with the NHS getting less out for the amount of staff, money, and other resources that it was putting in. This was understandable at first, with reduced capacity and major infection control measures introduced. But significant increases in staffing numbers have not been matched by equivalent increases in activity. Productivity is improving, according to some measures, at a faster rate than before the COVID-19 downturn, but still sits below the absolute levels being delivered pre-pandemic. The NHS desperately needs more capital funding to replace and improve its estate and to really make the most of the digital solutions that are now available. That is how it'll boost productivity, with modern facilities that support more efficient care rather than getting in the way of it. And what adds to the challenge is the broader financial context. The NHS is not the only public service or part of the economy facing financial difficulties. The whole public sector faces major financial restrictions. Some of this, like the well-recognised underfunding of social care, has a very direct impact on the NHS, leading to increased hospital admissions and slower discharges. But budget restrictions in other public services, such as education, and problems with poor housing and the general cost of living crisis, will all be contributing to demand on the NHS. It's a far cry from the NHS moving more into thinking about the wider determinants of health and focusing on population's health.
So, how realistic is the goal of achieving unprecedented productivity growth in this current climate, given the staffing shortages and the increased demand?
Well, first of all, productivity measurement is very complicated, but there are some real signs of improvement. A report from NHS England in February suggested that productivity in hospitals grew by 2.4% in the first half of 2024-25. That's more than double the historic productivity improvement in the NHS and means it's already hitting the government-set productivity target of 2%, which it set in the October budget. But the planning guidance issued by NHS England makes it clear that NHS organisations would need to reduce their cost base by at least 1% and achieve a 4% improvement in productivity in order to deal with demand growth. Well, this is off the scale in terms of past productivity improvement. More recently, we've seen integrated care systems in England told to rework their plans for 25-26, including a high level of ambition on productivity, after a first draft suggested an unacceptable overspend of some 6.6 billion. Those further drafts were submitted last week, and there's been a significant improvement in the overspend level, with just 5 integrated care systems forecasting an overspend of around 300 million above the level of deficit support that's been made available. As I said, there's broad agreement that delivering sustainable services in future means a much greater reliance on prevention, better lifestyles leading to reduced or delayed illness, and better support for people in the community to manage existing conditions, so avoiding exacerbations that need more acute treatment. But this means developing new models of care. These should reduce future additions to the waiting list, but they won't help address the current level of demand. And this all has to be done on a budget that's struggling to cover the current service model. Transitioning from one model to the other without the luxury of double running costs is the big challenge facing the NHS over the next few years. And I don't think we can overstate how big a role capital funding will play in improving productivity. There are large parts of the estate that are simply inefficient, theatres that can't be used because of maintenance requirements, wards that are off limits. This is a real drag on productivity, to say nothing about how modern, efficient buildings could really enhance care delivery. Ensuring services are co-located for maximum efficiency and better patient experience. The welcome new hospital programme has recently faced major delays in its timetable, but even that only scratches the surface in terms of the backlog maintenance carried by the NHS and the new facilities it desperately needs. And technology makes up a big part of the service's capital wish list. Without significantly more funding for capital, the NHS will simply not be able to maximise its productivity. It's arguably NHS finance leaders' biggest demand: give us more capital funding.
So, in regards to the transition of new models of care, how can this be afforded, and what role does technology play in this transition?
Yeah, again, it's a good question. There may be opportunities to stop doing things that are of limited value. One of the criticisms of the NHS is that it tends to focus each year on how it spends additional resources, the growth, when it should really be looking at whether it could get better value from the totality of its funding. Outgoing NHS England Chief Executive Amanda Pritchard told NHS leaders this year when she issued that planning guidance that she recognised the NHS will need to reduce or stop spending on some services and functions just to be able to live within its means. That's probably more explicit support for systems to actually stop delivering some activities than they've had before. And there continues to be huge variation across the country, both in the money spent on different services and the outcomes achieved. It's nothing new to hear the NHS being told to explore this variation to find opportunities to divert funding to activities that deliver better value. This analysis will have to increase if the services to find the funds to support these new models of care, arguably supported by much more comparative data on how funds are being spent across different programmes of care and what is being delivered for that level of spending. Technology has huge potential to improve productivity, both in providing more self-service support for patients and in supporting more efficient and effective clinical care. But this will need significant investment, especially after what Lord Darcy described as a decade of capital starvation.
Steve, thanks for joining us this week to break down the big news stories shaping NHS finance. As mentioned, Steve is the editor of Healthcare Finance, the official magazine of the HFMA. The magazine provides in-depth coverage of the financial challenges and developments affecting the NHS and the wider healthcare sector, offering expert analysis, insights, and best practices for finance professionals. The March issue is out now in both print and digital formats, so be sure to check it out. And for even more news, articles, and blogs from the editorial team, please visit the HFMA website to stay up to date with everything happening in healthcare finance. That's it for this week's episode of HFMA Talk. Thank you for listening. Don't forget to subscribe so you never miss an episode. And if you enjoyed the show, we'd love for you to leave a 5-star rating on your favourite podcast platform. See you next time. Goodbye.